Hi, I'm Matthew Goodwin from Washington University in St. Louis.
And I'm Wende Gibbs from Barrow Neurological Institute.
Thank you for joining today. I think the topic is discussing radiology reports. And so this is one of my favorite things to talk about because every day in clinic, it is something we deal with. And so I guess I'll start by asking about when you do a report, and let's say you're writing a report on an MRI of a spine. Now, which is different than 5 or 10 years ago, now that report is going to be seen by the patient right away. And that's new, that's different, right? And they're going to see it and they're going to read it before they've talked to me, before they've talked to you, before they've talked to anybody. And that may or may not set them off in a different direction. They might get very concerned and come in freaking out about their disc bulges. They might get convinced one problem's due to this or that. And so I guess so what I tell the patient, I'll start with that, is I tell the patient that their imaging and the report is part of their care. So there's going to be an exam, there's going to be history, there might be a nerve test, there's going to be other stuff, and it's all going to be taken into consideration. And but still, it doesn't solve the problem that patients see that report before they've heard that talk from me. And so I guess my first question is, have things changed for you guys on the radiology end and how you write the report? And how are things going to keep changing moving forward? And does that mean the reports need to be shorter, more layperson language, less? What does that mean moving forward?
Boy, okay, so there's a lot there.
There's a lot.
There's a lot there, but yes, so like 10 years ago, I think is when this started, like you said. This has been a huge deal for radiology. We want to empower the patients. There's big movement for patients taking part in their care. But as you said, it's difficult when a patient gets a report, subject matter they aren't usually familiar with, and what they do with that, how they react to it before they see you or their primary care doctor or whoever ordered it. It's difficult. And it's also difficult because the level of language we use might change depending on whether it's going to you or if a patient is going to see it. That's kind of hard for us to think about sometimes. We don't know who's going to see it first.
Right.
All of these things make it a very difficult thing for radiology. So I think what I try to do personally, I can't speak for every radiologist, I try to keep things simple because I am simple.
Because you know who's I'm reading it too. It has to be simple.
But no, me too. So I don't know. I try not to be fancy because I want everybody to understand it.
Right.
Basically, right. And I don't know if there's any reason to use fancy language unless there's terminology that is specific to the specialty that we're writing it for. Right. If there is some word that may be specialized, we have to use it. Right. Because we want to make sure the message gets conveyed correctly.
Right. Sure.
Otherwise, though, try to make it simple so that anyone, even different levels of in medicine. Right. There are different people with different amounts of training reading them as well, and so not everybody could maybe understand all the nuances. But so I try to tailor my language to everybody as much as I can. Try not to use alarming language if I can. Right. Or words that are unclear, like lesion. I like lesion.
I like lesion.
Or things that are either kind of lots of words that obscure the meaning or fancy words. And usually, I tell my trainees that the more words you use and the fancier they are, that usually means you don't know what you're talking about.
Right.
I think it is a lot higher level of knowledge to make something concise,
Agreed.
Answer the question to the point.
Agreed.
So that is what I aim for. I mean, I think most people do. It's harder also because we don't always have all the clinical information.
Right.
But as much as we can, if we have some great EMR and we can take that in, we've been training for 7 years too for subspecialized in like neuroradiology is 2 years. I don't know about other specialties in radiology, but so we can take our clinical knowledge also and give you an answer, make it concise if we take the time to do that.
What about cannot rule out?
So
there's so many levels of that. Some people don't say it. Some people will see a typical hemangioma. Right on T1, right on T2, you have the CT, looks all, it's all there. Yeah. And they will say, and I've seen this before, cannot rule out, and then list some stuff. And I don't know, so there's a lot of levels of cannot rule out, it seems like.
I would be interested to see if that's true both in academic places and in the community, because I think that's something maybe trainees do,
I
because
see,
that's the
I
way
see.
they're
Right,
taught.
right.
I never say that, ever. And I wonder if people like in private practice say that. I do not know the answer, because I don't read.
Interesting.
I don't know. But I do think that if you're seeing that, is more likely a trainee report that somebody has signed off, and
Got it.
maybe. That's my guess.
Got it.
The other part of that would be maybe people have a differential, either because there is one, although we try to make it as short as possible, or because of, medical legal. They don't,
I was gonna
some
ask you about
people are
that. So
very defensive, and they
Right.
don't want to miss anything that could get them in trouble later.
And how much does that come into play legally? Because you would think, I understand the reasoning, because I know I do lots of stuff where I say, this could happen, that before surgery. I tell them everything. And sometimes patients go, gosh, we know terrible things can happen. Just stop, just go do the surgery. We know all that.
Risk of death,
Yeah, you could die from the anesthesia. But how much of that, you would think that for a lot of these, if there were a legal issue, I mean, does that matter a lot if that language is in there? I just wouldn't think it would change much, but maybe it does.
So, boy, I don't know the answer. It's a big debate, and that's why people still do it. They don't want to risk, missing anything, not saying, oh, this could possibly be this, because we hear these big lawsuits about things that, it's just our society, it's just the world we live in. But at the same time, it's not useful. So if you decide, I'm a doctor, I'm trained, I'm doing a good job, I'm not going to put all that stuff, I'm just going to do my best and give you the two things it could be, rather than listing everything it could be.
Right.
It's a risk for me, but I'm going to take that because that's my job. In any given case, I don't know the answer. One of my favorite attendings in my fellowship said, what do you say? Better stupid than blind. So mention things in the body of your report, even if you don't know what they are, but you don't put those in the conclusion of your report.
I see.
That might be partly addressing what you're saying. I don't know. That's not a do not rule out, but it might be mentioning things that you think aren't relevant, and we don't exactly know what they are.
Right.
That's addressing the legal question, though. So.
Right. Interesting.
Yeah. Did that answer? Yeah.
I think so. So and so for the lesion thing, I have a talk that I tell patients, which is often, because I do spine tumors, and so I get patients that have spine tumors. I get patients that have spine infections. I get patients that have a spine. I tell them, lesion oftentimes because it says that somewhere, or they hear that. And I say, look, we don't know a lot of times. And I'm saying you have a thing, right? And that thing might be a nothing. You have a spot, and that's what we're talking about. And I spend a lot of time talking them off the ledge at the start of the visit, especially when we don't know a whole lot about it, right? Or if it's something that I'll tell them what I think. Hey, this looks like a benign thing. This doesn't look like anything. But here's what we're going to do. Whatever that, we're getting an MRI with contrast, or whatever the next thing is. But I spend a lot of time talking them off that ledge, especially if somebody's, used some funny language in that report. Mm-hmm. And then the other thing is, patients always want to know about things being caught earlier. That's a very common conversation. And, as you know, back pain is so common in the population that oftentimes people want to know, my back's hurt for, 9 months. How come this wasn't caught until now? Mm-hmm. And it's the same talk over and over. And it's like, well, look, back pain's very common. There's nothing to justify an MRI, after a week of back pain with no alarm, there are things to justify it, I take that back, but with no, red flags, et cetera, And so we kind of go through some of that. But it's an interesting question. And part of that question is, as a radiologist, when this comes up, one of the things that comes up is how come it wasn't seen on this image, right? It might be something that we see on an MRI, and they have an old CT, and if you go back, maybe there's a shadow, and they'll say, how come it wasn't seen here? And that's a conversation. But I don't know if that comes back to you guys ever, or how that works. But do you view your role when you're looking at an image of reading everything, even outside the field, right? So it's a spine MRI, but you're also gonna, if you see something in the kidney, comment on it. And do you always look at the stuff outside of the field? Because I'd imagine that would change what's included when it's a spine MRI. Usually,
and you and I just talked about this, radiologists, subspecialty radiologists, train just as long as surgeons. And if we have the clinical information, we can make, our job is also to diagnose. Yeah. So if I've read the history, I have a good indication of why you're getting the study. I know what your question is. I'm going to address that in my report. There are a million things in any given image. And if they're not, if they're not related to your question, and if they don't look worrisome to me, I am looking at it. I might not mention them though, if it's not relevant to the study.
Yeah.
I think there's so much. I mean, think about if you were doing surgery, would you, in your note, are you going to write down every single thing you see if it's not relevant to your thing?
Right.
So that's kind of similar. Outside of the field of view, I'm not sure what you mean by that exactly. I mean, if it's not in my picture, I'm not going to see
outside
it.
of the
but outside of that,
why we're getting that study,
that's
right?
We keep our field of view narrow.
Yeah. So,
Neuro.
so you see, see the kidneys and the spine MRI.
But then yes.
And
Yes, because that's often, that's something we teach our trainees, corner shots. You see that renal cell. Sometimes we're the first to catch that for sure. Or even on the scouts, you might see something that's not in our neuro, it's a very grainy, low resolution image, but you might see something there that looks suspicious that isn't even on the high resolution images that we're used to looking at.
Interesting.
So we do want to look at everything for sure, and we're still assessing everything, even if we're not talking about it.
Interesting.
If that answers your question.
Yeah.
So
you look at this, I did not realize that. You look at the scouts for that. That's great. Yeah.
We work hard.
Yes. Well, what else should the patient know about your report when it comes out? Because now they get it. They have them.
Yeah, I would say, again, that's such a tricky issue. It's good that they have they're empowered to make their decisions and get the care they need. But at the same time, I think that can be very overwhelming. So actually, I have two stories. My mother's friend, this is a story that really makes me sad. My mother's friend said, her mother had gone to the neurologist, she had some memory problems. This is not spine, but it's related to the issue. And she'd gone to the neurologist and I was getting an MRI, and the MRI report said she had white matter disease, which is not what the neurologist told her. The neurologist said, oh, you have leukoariosis. Those are two words for the same thing, but the patients don't know that. And disease, white matter disease, she thought she thought there was something really bad going on, which, in a way. But anyway, so this poor patient, this woman's mother, was so upset and confused, and they both were, because they're like, this is this, I don't know what to think. So even though they had gone to their doctor, there was still confusion. So my big thing is standardization of language. I think that is huge for radiology. We're working on that. Anyway, so that's hard for patients. But the other thing is, they just need to be careful about go to your doctor right away. Go to whoever ordered it right away. Get the expert who ordered it to tell you about it, because just having that on their own, which also happened to me before I went into medicine, I had a CT for a neck injury. It said I had a thyroid nodule. I thought, wow, what is this? This is terrible. Next time I went to my primary care, I'm like, I have a thyroid nodule. She's like, but it says here I have these nodules. And it was really scary because I didn't know what that was.
Right.
And I had not Googled it, which might have even made me more scared. I don't know.
Right.
But I think it is hard. And I think I realize it's a hard thing for radiologists to deal with all these things, because we can't be perfect for everybody, but we try.
Sometimes the radiologist will include lines like consistent with normal degenerative changes. And that seems to tamp things down with the patient, where I can explain it and say, look, they also are mentioning that they're going to talk about all this, but this is gray hair and wrinkles, this is degenerative change.
But we don't, that's also hard. That is hard. So I would rather not mention it at all unless you're getting the study for that reason.
Yeah.
So in a study, we were talking before, if everybody has back pain, everybody has degenerative changes if you're over 20 something. And so going level by level, detailing everything, I do not think is useful unless that is what you really want. So I'm here to find something more severe.
I'm with you. We're on the same page.
You mentioned that before, and I didn't answer it, because now I remember one of your multi-part questions. We're there to see the systemic disease, the osteoporotic compression fracture, the occult cancer. That's what our value is.
Yeah.
So I'm sticking with those things. Or if you say, left L5 radiculopathy, I'm going to address that.
Right.
But really everything at every level, and any report that's more than this long to me is too long. Yeah. Nobody's reading it.
Yeah, I agree.
No, me, you, nobody.
So
this is, but that's why we train our trainees. So we try.
Standardization of language.
Yes.
Stenosis. I actually don't. I don't know. I don't think I've ever asked you this. I should have asked you this. I always am reading different mild, moderate, severe language, and we're taught, certainly in my training, not to use those words.
Oh.
And then we talked a little bit about, depending on, 8 millimeters, 10, what's, and then you can compare it to, there's all these different things you can do, but we're kind of taught, I think, not to, because then it gets into the what does that mean? I think it's I think there's a lot of reasons why that is, but I do notice that that's used in reports. I don't think it's standardized on the radiology side. Maybe you'll tell me it's supposed to be, but it doesn't seem like it is. Is it supposed to be?
Moderate, severe, like canal stenosis?
For foraminal, for canal, people use it. I don't know if there's supposed to be a standard. I don't think I figured it out from what I read from them.
So
from you guys.
Thank you for saying different. There is a system, there was a pretty classic paper, maybe 20 years old now, I don't know, for lumbar stenosis that I think almost all people use.
Central.
Yes, canal stenosis. And foraminal stenosis, but there is not for cervical or thoracic. So if anybody's applying it in any other places, then there might be a cervical thing, but fewer people use it. But lumbar, I would say it's not standardized, but it's commonly used.
I see.
So it's funny that you would say it that way, because one of our other spine surgeon friends that I work with said, oftentimes surgeon will call you and say, you called this moderate foraminal, but can you call it severe? Because I can't do surgery unless you call it something.
Oh, interesting.
And so some surgeons want us to call more.
I see.
Because the patients really need surgery, but insurance, he said, insurance will will listen to anybody but you.
Yeah.
The surgeon, right? They'll take any evidence not to let this happen, and so
that's interesting. I actually have had stuff like that happen where it's downplayed a little too much in the report, and it's clearly the problem.
And that's so. In my training, I was taught spine surgery is bad, believe it or not, and so they said, always downplay stuff, or some surgeon's going to come in and do surgery, and it's terrible. By really famous radiologist, by the way. But now I've, working with surgeons like you, and I don't know if I should name names because he's probably been on this Ask the Experts recently too. I've gone the other way. So I don't overcall things, but at the same time, I'm very cognizant of what you are looking for.
Right.
By talking to you all, and in that way, I think we can better help our patients, because that will allow you to do the surgery that I know you have the judgment to say the patient needs.
Oh, that's so interesting. These are always, I learn something every time we do this. That's pretty good.
Me too.
Well, that's great. We are probably about out of time. So thank you again for doing this. It's always fun. I always learn, and hopefully others learn as well.
Thank you.
Thanks.